Abe. So we'll first tell you a little bit about him, his credentials, and then we're in for a very pleasant talk from him. Can you hear me if I don't use this? Can you hear me? Oh, that way. Is that better?
It's a directional
There you go.
microphone.
All right. Tell you a little bit about Dr. Abe's history. He was, he is our pulmonologist here at Peninsula Pulmonary. He went to just a second, Occidental College in Eagle Rock, and then he. No, thank you. Is that from you, Dr. Abe?
No, that's just the talk.
I will just give you a little bit of history about him. He went to Occidental College in Eagle Rock, and then went to Drexel College or University in Philadelphia for his residency, and then to Harvard UCLA. He has been practicing since 1998, so that's 15 years that we've had him. He is a co-director of the ICU here in Torrance Memorial Hospital. And what else can we tell you about his history? I think that's about it, or that I know. But one of the things that is so special about him is not just he as a person or as a doctor, but the care that he gives to each of his patients. I had a very unpleasant experience back about a year ago of having gone to Duke University for a lung transplant. And the whole experience did not turn out well. And month after month, he sat and listened to my post-traumatic recounting of what had happened, never with a look of enough already, never stopping me, just letting me go on about the experience that I had had with empathy, his empathy. I have never seen him be impatient. I have always experienced him to be very willing to listen as long as you wanted to talk, and to never be critical about anything that you might have been feeling, either by look or action or word. So it is my great pleasure to introduce to you Dr. John Abe.
Thank you, Nan, for that very nice introduction. I hope I live up to it. Thank you also for just giving me the opportunity to be here and to talk to you guys. It's my first time, and it's a wonderful experience. You can see why you guys all want to come back. As I was preparing this talk, and this talk is about lung cancer screening, I started thinking that, boy, I hope I don't depress people, because lung cancer is not the most uplifting subject. But I just want to tell you briefly what my goal is right now. My goal is to try to educate all of you who are here, especially those who might be at risk for lung cancer, what lung cancer screening is about, so that you can use that information to make the best decision for you as an individual, along with your doctor, about whether or not you should enter into lung cancer screening. So that's what I want to do. My goal is not to say each and every one of you who might be at risk should go out and do it, but to give you the knowledge and the power to make the right decision, and to make a decision that's right for you. So I got excited about this talk because when the news came out about lung cancer screening being an effective tool about 2 years ago, I thought this is great, because for so many years we didn't really have anything. And just to give you an overview about lung cancer is actually the most common cause of cancer death in the United States. And a lot of people don't realize that because it's not publicized as much as some of the other cancers. So if you look at the next 3 most common cancer causes of death, which would be breast, colon, and prostate, lung cancer deaths combined account for more deaths than all 3 of those cancers together. Okay, so
Can you speak a little louder than I don't know?
sure. So there's a handout, and I don't want to kill you with numbers, but if you look at worldwide, there's 1.6 million cancer cases identified every year. There's 1.4 million cancer deaths a year worldwide. In the United States, you're looking at about 230,000 new cases of cancer diagnosed every year and about 160,000 cancer deaths. So those are really big numbers, and a lot of people don't realize that. And in my personal practice, I probably see every year maybe, I'm trying to think, I'm thinking maybe 25 to 30 patients I diagnose with lung cancer every year. And I've been doing that for 15 years. So it's a lot. What about women? One thing that you need to know also in comparison to other cancers is that women have not twice as much of a chance, but twice as many women die from lung cancer than die from breast cancer. So again, everyone talks about breast cancer, everyone knows about breast cancer, you see it on TV, but people don't talk as much about lung cancer. So what are the risk factors? I think everyone knows what the main risk factor is. We know it's smoking. About 90% of men who are diagnosed with lung cancer have smoking as a risk factor. For women, it's a little bit less. It's about 70 to 80%. And there are different reasons for that. Some we think are genetic, and some have to do with lifestyle, socialization, things like that. Now, what happens to your risk of lung cancer after you quit smoking? For people who quit smoking, their risk will gradually go down over a period of about 15 years, but it doesn't go down to the same as the risk of a person who has never smoked. So it will still remain roughly twice as high as people who have never smoked. And in terms of the relative risk, how much smoking leads to how much risk, if you smoke 1 pack of cigarettes per day for about 40 years, your risk of cancer is about 20 times as much as a non-smoker. Okay? There are other risk factors, things like asbestos we all know about, radon we don't have to worry too much about here, but it is in the environment, and other things that are that people are more exposed to through certain occupations. So why is lung cancer such a deadly disease? If you look at the bottom of the second page, I gave you some numbers. If you look at cancer, cancer is divided into 4 different stages. So stage 1 would be the earliest stage, stage 4 would be the latest stage. And if you look at the survival, if you're diagnosed at a late stage of cancer, stage 4, your survival is only about 9% for 5 years. So 9% of people who are diagnosed with advanced cancer will be alive in 5 years. If you happen to catch it at an early stage, so if you look at 1A, the survival is 73% in 5 years. Okay? A 1A tumor, 1A cancer, is a cancer that's less than 2 centimeters in size. A 1B cancer is somewhere between 2 to 3 centimeters in size. So if you catch a cancer when it's at a very small, or at an early stage, when it's small, when it hasn't traveled to the lymph nodes in the center of the chest, when it hasn't traveled outside the chest, you have a decent chance of cure. The reason why lung cancer is so deadly is because most of the time when it's diagnosed, it's not stage 1. It's usually stage 3 or stage 4. And if you look at those statistics, only 13 to 9% of people are alive for 5 years, and you're diagnosed at that stage. So that's what I want to talk to you guys about, is what can you do if you're at risk to try to improve your chances, to try to catch that cancer at an earlier stage, at a stage when it's potentially curable. So let's talk a little bit about screening. What is screening? I think pretty much everyone probably knows what screening is, screening for cancer. The whole goal of screening is to identify someone with cancer at a stage when they're not symptomatic. So identify it when it's early, before symptoms are apparent, and at a stage where presumably you can make a difference, where you can alter the survival, improve the survival. What are the characteristics of a good screening test? A good screening test should first of all be able to identify the disease when it's there. So we call that sensitivity. So a screening test should be highly sensitive. You don't want a test that's going to miss something that you're looking for. You don't want a mammogram that's going to miss a breast cancer. You don't want a colonoscopy that's going to miss a colon cancer. The other thing it should be is what we call specific. In other words, if you see an abnormality with this test, that abnormality is because of whatever it is that you're looking for. So if you see an abnormality on a mammogram, you want that abnormality to be what you're looking for most of the time. You don't want it to something else. The other characteristics that you want in terms of screening tests is you want it to be fairly safe, something tolerable, something that's acceptable to both the patient and the doctor. And then the last thing is that it should be cost-effective and relatively low cost, just for practical reasons, because if it's not, then no one's going to pay for it in the general. So why is it that only a year and a half or 2 years ago we actually found something that we could effectively use to screen for lung cancer? It's not because we haven't tried. Since the 1950s and especially the 1960s, we've been looking at things like chest x-rays and sputum cytologies to try to identify lung cancer at an early stage. For those of you who don't know, sputum cytology is when you cough, bring up your sputum, put it into a container, and the pathologist will look for cancer cells in it. So what we found with all these studies from the 50s, 60s, onto the 70s was that chest x-rays were not effective at reducing mortality from lung cancer. It actually identified people with earlier stages, but it didn't change mortality. So by the time we were in the mid to late 70s, we pretty much gave up on the concept or the idea that chest x-ray screening was something that we could use to effectively screen people. That being said, they left it up to individual practitioners to decide along with their patients whether or not x-rays should be done with the intention of quote-unquote screening. And up until just recently, that's something that I did. Because on an individual basis, you can still make a difference, even though looking at large populations, you may not be able to. So what happened is, when we came out with CT scans, as you probably know, CT scans are much better tests than chest x-rays. They can pick up much smaller abnormalities in the lung. They can pick up nodules that are in the lung that are about 2 millimeters or 3 millimeters in size. So roughly the size of a grain of rice. And being that sensitive of a test, we thought, well, maybe we could use this as a way of screening people for lung cancer. And we found, in our own practice, just incidentally, we always get people who come in with a nodule that was incidentally found on a CT scan of the abdomen. So if someone's got abdominal pain, they get a CT of the abdomen, we find a little tiny nodule in the lung. We watch it, gets bigger, gets big enough, we take it out. And we oftentimes find out that these are cancers, and we were fortunate to have just happened to find it. And those are the people that we can actually cure. By the time you have symptoms, as I said before, you're probably at a pretty advanced stage, and at a stage where you may not be able to cure you. So what happened was the National Cancer Institute in the early 2000s decided to do this big study. It's the biggest study ever. It still is so far. Looking at CT scans, low-dose spiral CT scans, as a means of screening people for lung cancer. And they looked at about 50,000 people, ages 50 to 74, with a 30-pack-year history of smoking. So people who on average smoke about 1 pack of cigarettes per year, or per day, every year for 30 years. Okay, so they looked at active smokers, and they also looked at people who had quit within 15 years. The median they followed on average these people for about 3 years. Well, I shouldn't say that. They did x-rays and CT scans at the onset of the study, and then for 2 years afterwards. So they looked at people for a total of 3 years. And what they found was that there actually was a significant reduction in mortality. And if you flip the page, I think it's the 3rd or 4th page, I actually gave you some numbers. And again, I don't want to overdo the numbers, but suffice it to say that there was a 20% reduction in mortality. Okay, so not only did they identify more cancers than chest x-ray screening did, it actually led to a reduction in cancer deaths. Okay, a 20% reduction. So it's hard to look at that number, without looking at it in the proper context. Everyone knows about breast cancer screening. Everyone, I would imagine most women here, if not all the women here, have had mammograms at one point or another. What do you guys think is the risk reduction for mammogram screening for breast cancer? Do people think that it reduces your risk by 30% or mortality by 30%? Does it reduce mortality by 20% like CT scanning for lung cancer does? Or is it 10%? So does anyone say 30%? Who would say 30%? How about 20%? How about 10%? Well, actually, I was surprised, but I didn't actually know this until I prepared this lecture, is that it only reduces your risk or your mortality by 10%. Whereas lung cancer screening will reduce your mortality by 20%. Okay, so that's pretty amazing, actually, when you look at it. When you look at all the people that get breast cancer screening, and it's, even now, it's very rare for people to get lung cancer screening at this point. So what are the things that we find? We found that we were able to, as we suspected, catch cancers at an earlier stage. So we found a lot more stage 1 and stage 2 cancers. We also found that as each year went on, we were still picking up the same number of cancers. So what that implies is that even though the study only screened people for 3 years, it would seem that if you continue to screen people, you could continue to reduce mortality. The study was ended prematurely. It ended after about 6.5 years of follow-up because it was considered unethical to continue the study because we already had these results that were so great. So they terminated the study in 2010. The results were published in 2011 in the New England Journal. It got a lot of buzz at the time. And at that point, both the little company of Mary and Torrance Memorial decided to introduce into the community a lung cancer screening program. But I know that at Torrance and even at Little Company, they haven't gotten many takers. There aren't many people who have been getting for some reason. We're not quite sure why. So what are the main lessons? The main lessons are that it reduces mortality with CT screening, that chest X-ray screening does not reduce mortality, that CT screening is more sensitive than X-ray screening in detecting small cancers. The other thing is that it detected, as we thought it would, a lot of what we call false negatives. Okay? It detected a lot of nodules and abnormalities which turned out not to be cancer. So that's the potential disadvantage. And if you remember when we talked about what a screen test should do, it should identify the abnormality or the cancer when it's there, but you don't want it to identify other things. Now, unfortunately, with CT screening, it does identify a lot of other things. And a lot of these other things mostly are just little benign nodules. They're just little areas of scar tissue that are formed. We see it very commonly. And most of the time when this was found, all we did is follow it with serial scans. And if it didn't get any bigger, we didn't do anything about it in this study. Okay, so it was rare that finding one of these nodules led to a test, a biopsy, an operation, and potential complications. Okay? But it is a potential downside. So there are some unresolved issues. We don't really know what the risks are of the radiation. These are considered low-dose CT scans, but there is still a considerable amount of radiation, and if you're going to get multiple CT scans over a period of many years, that does need to be taken into consideration. And as you probably know, radiation is a risk for cancer itself. The other thing that we don't know about is how effective is the screening outside the parameters of the study. The study looked at people who were age 50 to 74. Well, what about someone who's 75? What about someone who's 45? We don't know. We assume that there's probably still benefit, but we don't know for sure. The other thing we don't know is how to risk stratify people. For instance, this study didn't give any information about whether these people had COPD or not. Amazingly, they collected a lot of information, but they didn't collect that information. Or they might have that information, but haven't published it yet. Okay? But I don't know if you realize, but people who have COPD, given the same amount of smoking, are actually at higher risk than someone who doesn't have COPD. So let's say you have a 30-pack-year smoker who doesn't have COPD, and another 30-pack-year smoker who has COPD. That person with COPD is actually at higher risk, even though they smoke the same amount of cigarettes. The other thing we know is that people with COPD, the worse your FEV1, the worse the lung function is, the higher your risk. So even among people who have the same amount of smoking, one person who has mild COPD will have less of a risk than someone who has severe COPD. Okay? So again, this study didn't risk stratify those people. It didn't say, well, it was more effective for people with severe COPD or less effective for people with mild COPD. We just don't have that information yet. But hopefully they will publish further data as time goes on. The other thing that's a potential downside, and I hope it's not a real downside, is what impact does this have on your quality of life? For some people, knowing that they're being screened can be a reassuring thing. People will feel empowered. They'll feel that I know what's going on with my body. I know that I did a CT scan and they didn't find anything. They'll feel better. Other people will feel uncomfortable. Let's say someone gets a screening CT scan and they find a 4-millimeter nodule. Are you going to feel better or are you going to feel worse? Are you going to be up at night worrying about it, or are you going to feel more reassured that, hey, my doctor found this and he's keeping an eye on this? And we'll find out if it gets bigger, we'll know that it might be cancer and we can do something at an earlier stage. So that's one of the things that I was talking about earlier, about how you've got to make the right decision for you, because it kind of depends on your personality and how you look at things. I would hope that most people would want to know. I would hope that most people would feel more comfortable having that knowledge and knowing that they're being watched more closely, because the data do show that if you do this, there is a 20% reduction in mortality. But again, not everybody's the same, and certainly I have patients in my practice who opt not to go for lung cancer screening. The other thing I didn't mention, there was an incidental finding that there was a reduction in death from other causes. That was another thing that was kind of interesting about the study, and we don't know why. We don't know why there were fewer deaths from other causes as well. So what to do at this point? I think that if you are one of those people who fall into the category of people who are screened in this study, if you're age 50 to 74, if you have a 30-pack history of smoking, if it's been less than 15 years since you quit, I think that it would be reasonable to undergo the screen if it's done in the right setting. Okay, so if you are making an informed decision about it, if you have a physician who you can work with who will guide you through it, and it has to be done in the context of a multidisciplinary team. Okay, so you can't do it in isolation with just your internist, say. You've got to have a good radiologist who's going to interpret the CT. You've got to have people who will allow, or good surgeons. If you need a biopsy, you need to have that person available. You need to have good interventional radiologists if you need a CT-guided biopsy. So it has to be done within the context of a whole team of people. That's about all I have to say about it. I hope I've given you some information about this. Are there any questions?
Dr. Abbey, how about insurance coverage? What's the situation there?
That's a great question. There is no insurance coverage as of yet. Okay, so there are several major medical groups who have advocated lung cancer screening. But so far, Medicare hasn't paid for it yet. Once Medicare decides to pay for it, other insurance companies will probably follow suit. I think that because the information is still pretty early and we only have this one study that shows that it's beneficial, I don't think they've come out with that yet, but hopefully they will.
How about the question of PET scans as far as follow-on to CAT scans?
Okay, so the question was, what about PET scans as a follow-up to the CT scan? If the lesion looks suspicious enough and it's greater than 6 or 7 millimeters in size, a PET scan would be beneficial. So for those of you who don't know, a PET scan is a type of scan that detects metabolism within a nodule or a tumor. So if there's a cancer there and it's greater than 6 or 7 millimeters in size, it will light up on a PET scan. So that's a tool that we use to determine whether or not a lesion is suspicious for cancer or not. If it lights up, we'd be more suspicious of cancer. We'd be more apt to do something like an operation to remove it. Yes?
I've had a couple of high-res CT scans for pulmonary fibrosis. Is a low dose CT still necessary, or is the high-res okay?
Dan asked a question about a high-res, is a high-resolution CT scan effective? A high-resolution CT scan takes 1 millimeter thick cuts every 10 millimeters. Okay, so you're missing 9/10 of your lung when you do a high-resolution CT scan. So you could easily miss a small nodule in between those cuts, those successive cuts. So it's a different kind of a CT scan. So the answer to your question is that a high-resolution CT scan is not a good screening tool for lung cancer.
COPD and lung cancer with this influx of states okaying smoking for therapy? Therapeutic, marijuana?
Oh. The question regards marijuana and the legalization of marijuana and whether or not that will lead to an increase in COPD or lung cancer. I would say yes, it will lead to an increase in COPD. Well, I shouldn't say that will. Marijuana smoking does increase your risk for COPD. Okay, it can cause COPD. Okay, as far as lung cancer goes, we don't know. Yes.
No insurance coverage, so what is the cost for this?
At Torrance Memorial, I believe it's $325 or $350, but
For a skin?
for one scan. But let's say that you find a little 4mm nodule that you see on the screen CT scan. Then your insurance will then pay for the next CT scan because now you have a medical reason, a medical indication. You've got a lung nodule,
Yeah,
and it is indicated to have follow-up CT scans for a lung nodule.
But then it's too late, you've already.
No. Even if it's a benign nodule, okay. Let's say you do a screening CT scan, you pay your $350 for that, but you find a 4 or 5mm nodule in your lung, okay. That in all likelihood, you have a 95% chance that that nodule is not cancerous, okay. But because you have that nodule there, you can then get your next CT scan paid for by insurance because now you've identified an abnormality.
So if they should find one in your lung, how soon do you think you should have another one? CT.
It depends on what you find, okay? So it would depend on how suspicious it is for cancer versus how likely it is to just be a benign nodule. If it's an isolated 3mm nodule, in all likelihood, we'd wait 6 months for the next CT scan. If that one was okay, we'd wait a year for the next one. And we generally follow these little nodules for a period of about 2 years. And if they don't grow, we don't get any further CT scan in general. Okay? But if you're talking about further screening for lung cancer, then yes, we would do subsequent CT
I've
scans.
smoked for 55 years, so I'm in trouble.
Yes.
How about when you're older than 75, 80 or 85?
Good question. The question was, should screening be done after the age of 75 or beyond? That's one of those questions we haven't answered yet. So we didn't look, in this national lung screening trial, we didn't look at people who started the trial before the age of 75 or after the age of 75. So we don't know the answer to that. My advice to patients would be that if you're in otherwise relatively good health, that it would still make sense to screen. And that's about all I can say. Because there still should be benefit, but we just don't know.
How often can you take a CT scan before they consider that excess radiation?
Well, radiation is cumulative, so your risk, it goes up linearly. So the more CT scans you have, the more risk you have of developing a cancer. We don't know that there's an absolute threshold or a cutoff where we would say you can't have any more CT scans. Obviously, we want to limit it as much as possible. The hope is that as the technology improves, the amount of radiation we have to give for each CT scan will decrease over time, so that risk will diminish over time.
Other than the possibility of cancer from too much exposure to radiation, what other dangers are there? What other things can happen to you with too much radiation?
Other than cancer?
Yes.
From a CT scan, well, I mean, radiation, for instance, the radiation that we give to actually treat a cancer is a much higher dose, and that can cause problems with tissue damage. As far as we know, there's not that kind of damage with CT scans. Yes?
I have another question about CT scan. Say, one year you have 3 CT scans, and the next year maybe you have 2. The next year maybe 1, and then maybe 2 years pass. It's still all accumulating, right?
Yes.
Okay.
Yes,
And
those
so
risks
the
are
early
cumulative
one-
over your lifetime.
So the early ones you had might have been stronger than the later ones? And, okay, I don't know how do doctors rank or justify the need for the CT scan?
It's all a risk-benefit analysis, really, is what it comes down to, is what are you looking for and what would you potentially miss if you didn't get the CT scan? So it's the same is true for, CT scans for screening for lung cancer versus getting a CT scan for someone who's got abdominal pain in the emergency room. Use the test to try to identify what's causing the problem, and you have to justify it. You have to make a decision of whether or not that CT scan is justified. So if you come into the emergency room with abdominal pain, you do your battery of tests, you do an x-ray, you still don't have an answer, most doctors would go to the next step to try to find out what's causing that pain. Yes, Kurt?
Doctor, how about hereditary factors? If one of your parents had lung cancer, does that vastly increase propensity to get it?
I don't think we know the exact amount of risk there is there. That's a great question because, there are going to be people who come to me and have asked me, and I can't always answer. Well, they'll say, well, I've had a lot of secondhand smoke exposure and my father died of lung cancer, but I personally have never smoked. Should I be screened? I can't really answer that. I can say that you probably are at some increased risk with the family history, but it's hard to quantify. We don't have that information.
Thank you.
So my husband didn't ever date because I smoked for all those years.
Well, the risk from secondhand smoke exposure is much, much less than firsthand smoking, but there is risk there.
Because he never smoked.
So, Dr. Abbott, when you say the radiation is dangerous, which we all have known, what about iodized, what do you call it now? Radioactive iodine?
Radioactive iodine.
Yeah, what, is that significantly worse on a continuum, you know?
I don't know. I don't know the answer to that. I know that there is risk, obviously. When a person gets radioactive iodine treatment in the hospital, they're put in a room by themselves. Nurses and doctors try to minimize contact because there is a certain amount of risk. The technicians who work in the hospital who administer it have a badge on that basically counts how much radiation they're getting so that they don't get too much. So yeah, there is risk from radioactive iodine, but exactly how much in comparison to a CT scan or multiple CT scans, I don't know.
Is it the same kind of radiation that you're accumulating from the radioactive iodine, or is it a different kind of radiation? I don't know if there are different kinds of radiation, but
It's just different wavelengths, but it's still radiation. All right. Oh, one last question. No, MRIs, I get this a lot because people are concerned about radiation. When I recommend a CT scan for whatever reason of the chest, people always say, well, why can't I get an MRI? The reason we don't use MRIs is because MRIs aren't good at imaging the lung. They're good at imaging soft tissue. So your joints, your ligaments, your tendons, your muscles, your spine even. So it's good for those things, but not good at imaging the lung, unfortunately. It would be nice if it was.
Sometimes you have an MRI, they send you back for a CT.
or vice versa?
Yeah, I mean, I could imagine that, sure. Sure.
Is that a lot of radiation?
Well, the CT has radiation. The MRI has no radiation. No radiation at all. Oh, yes.
Is there any thing like potassium iodide that you would take before a CT scan to make the radiation less accumulated?
Not that I'm aware of. The question was, is there anything like potassium iodide that you could take before a
few
CT
years
scan?
ago, it was recommended when the thoughts of a dirty bomb might go off here in the States somewhere, people should get potassium iodide pills and keep them.
Yeah, as far as I know, no.
Yeah.
There isn't.
Okay.
All right, well, thank you.